Injury to the fingertip is common and can be debilitating secondary to the forces placed on the digits. Management of these injuries should be aimed at preserving the length of the digit when possible and providing soft tissue coverage with protective sensation at a minimum. Although microsurgical techniques have enabled replantation of even very distal tip amputations, it is relatively uncommon for a distal tip injury to be suitable for replantation. However, when the amputated part is not suitable for replantation, an alternative tool for reconstructing the distal phalanx with preservation of the finger length should be available. The essential goals of fingertips are the following: maintaining length, restoring sensation, appearance, and to restore active range of motion at the distal joint. Evans and Martin first reported the step advancement flap in 1988. The advancement of a neurovascular island flap to repair fingertip damage is a well-established technique. Joshi, 1974, Venkataswamy and Subramanian, 1980, Schuand et al., 1985. Theoretically, the entire side of the finger could be advanced distally, based on one neurovascular pedicle, but the use of long island flaps carries the disadvantage of a longitudinal midline volar scar, risk of flexion contracture. To overcome this problem and yet be able to utilize large flaps to reconstruct defects requiring up to 2 cm of advancement, the principle of step advancement had been applied. This technique of repair is applicable to defects of the fingertip which are too large to allow simple skin closure or volar VY advancement, Atasoy et al., 1970, without distortion of surrounding structures, and too deep to allow the use of a free skin graft without adhesion to underlying bone or loss of satisfactory tactile pulp. It is not advisable to use the technique in the elderly or in arteriopaths or heavy smokers. The digit must have 2 patent digital arteries, confirmed by the digital Allen's test or Doppler examination, and the requirement for advancement should not be more than 2 cm. The technique provides tissue to support the nail if that has been preserved, and allows stump coverage without shortening in more proximal amputations. The repair is carried out under regional block or general anesthesia, and arm tourniquet control. The flap is raised on whichever side of the digit provides it most readily, but the least used side of the finger is preferred. The design of the flap is critical, the distal segment being the key area, since this provides cover for the original fingertip defect. The volar incision, which is made first, comprises 3 triangular flaps, narrow proximally and wide distally. The distal wide triangle just crosses the midline to poach slightly from the other side of the digit, but the proximal flaps are confined to the affected side. These triangles are not separated from the underlying subcutaneous fat, but the corresponding triangles based on the other side of the digit are raised thinly so that a longitudinal subcutaneous dissection can be made in the midline of the finger, protecting the neurovascular bundle. The dorsal incision is gently convex, maintaining adequate width at the narrow segments and coming to a point proximally with a triangular flap on the line of the neurovascular bundle. The island flap is now raised from distal to proximal on the plane deep to subcutaneous fat, keeping the neurovascular bundle with the skin. Small branches have to be divided, but if a larger dorsal branch is encountered running distally, it can be preserved since it will slacken as the flap moves distally. The network of fibrous tissue that tethers the skin to the underlying structures has to be freed, and as the proximal pole of the flap is reached, this dissection should be carried more proximally so that the neurovascular bundle is mobilized. Only when the neurovascular bundle is completely mobile can the dissection be considered complete. It should now be possible to advance the flap, engaging each triangular flap 1 step distally. If it will not move far enough, the neurovascular bundle should be further freed, dividing every last strand of fibrous tissue that tethers it. Some hip joint flexion can be allowed to feed the flap distally, and provided this is fully extended at 5 days, there need be no fear of flexion contractures. Nevertheless, this complication must be consciously avoided. The tourniquet is released and the circulation checked. Suturing commences at the points and angles of the volar zigzag. The distal segment of the flap is sutured into the tip defect where it should restore the proud convexity of the fingertip pulp. Finally, the dorsal incision is sutured, though it is usually found that complete skin edge apposition is impossible. A gap of up to 4 mm is acceptable and will heal down to a narrow scar. The flap must not be put under tension. Smaller multiple triangular flaps are used, not necessarily 3 flaps, to ensure better fitting after advancement and close without tension. The dorsal incision is along the mid-axial line, dorsal to the neurovascular bundle, and coming to a point proximally with a triangular flap on the line of the bundle. Always keep a cuff of subcutaneous fat around the neurovascular bundle, i.e. don't skeletonize the bundle. No traction is allowed on the pedicle. If it is the situation, you extend the release of the neurovascular bundle through the palm till the bifurcation of the common bundle. I start first by suturing the distal segment of the flap into the tip defect where it should restore the proud convexity of the fingertip pulp, then interlacing the triangular flaps. In case more advancement is needed, you can bypass the proximal 2 triangles, i.e. 2 steps advancement. Think twice before doing such technique for diabetic or hard laborer patients.